So Isabella and I are going to talk about development and use of the ICECAP measures, and this is just an outline of what we're going to talk about today. So I'm just going to start off with a little bit about why we might be interested in capability, and then we'll talk about how the ICECAP measures have been developed, and as part of that, Isabella's going to present a case study of her work on finding out about conceptual attributes for a capability measure for young persons who have life-threatening and life-limiting conditions. We're then going to just talk a little bit more about the different ICECAP instruments so that you're aware of what they all are. We'll think briefly about whether a capability focus makes a difference, and then we'll talk a little bit about some work around decision making with ICECAP, and then I'll just offer some final thoughts. So hopefully that's what you were expecting to hear. So let's just start off with thinking about why capability. So as you all know, we have to make choices in health and care. If we spend our money in one area, then we can't spend it somewhere else. And one of the ways that we think about that very often is by using economic evaluation or tools associated with economics to help us to make those choices. In the UK context, we have NICE, and NICE aims to improve health and social care through evidence-based guidance, but it's not just evidence-based guidance. It's also about values and the values that go into the evidence. So much of the evidence we generate has value judgments all the way through it, and those value judgments are not the same in every jurisdiction or area where sorts of decisions happen. So some focus on particular types of health measure, some focus on particular types of decision rule, but they aren't the same everywhere. And these are just some terms that you might see sort of within this area of thinking about decision making and decision making processes. So things like utility and money and health and capability and well-being are all different types of evaluative space. And then there's also how do we combine the information within that evaluative space to make a decision. So do we aim to maximize? Do we aim to provide sufficient care and so on? So there's all these different choices that we have to make about how we make decisions. And why do we choose one rather than another? So the capability approach is what we're going to talk about today, and this is work that was developed by Amartya Sen. So what Sen said is that what's important in decision making is not utility but functionings and capabilities. So he defines functionings as what an individual does or is in life. So it might be that they're socially respected or healthy or well nourished, but capabilities are about what an individual is able to do or be, whether or not they then choose to do or be that thing. So in Sen's view, opportunities are important even if individuals choose not to pursue them. Why is that? I think there's two reasons I think why we might be interested in capability. One of those is a theoretical reason. So this is an example that Sen very often uses about comparing the starving family with the fasting family. So a starving family is unable to eat because they don't have food available to them, whereas a fasting family chooses not to eat. So they have food available, but they've made the decision for religious reasons, for example, to not eat. If you just looked at both of those in terms of functioning, you'd see the same thing, that they had reduced nutrition, for example. But if you think about it in terms of capabilities, there's clearly a difference, because in one situation there is the opportunity to eat, whereas in the other situation there isn't. And that's why Sen particularly likes this focus on capability. For me, myself, my interest in capability came about really through data. So work that I was doing back in sort of 2003, 4, 5 was looking at developing a measure that would cross health and social care, and trying to do that from the perspective of the people who would receive that care, so from the perspective of older people specifically. And what we found when we did those interviews is that people talked a lot of the time, or almost all the time, in terms of capabilities. So they talked about what they could and couldn't do. So these are just some quotes. The ones on one side are more negative and on the other more positive. But I lost all my friends when I couldn't go out. For 7 years, I was looking after both my husband and my mother, who was beginning to go senile. For the first time in my life, I'm dependent, which is not very pleasant. I can't go out as I did a few years ago, take the car and go swimming. So decrements in capability. Whereas on the other side, I can choose. I can choose who I spend time with and so on. And we're fortunate insofar as we've got the two pensions, we're able to go off. We grabbed a cheapy flight at the end of April. So you can see that people are thinking in terms of these capabilities. And that specifically was what led me down the route of thinking about capabilities. So this is a quote from Sen in relation to the capability approach. He says, it differs from the standard utility-based approaches in not insisting that we must value only happiness, and sees instead the state of being happy as one among several objects of value. So this is very much comparing with the standard approaches used within mainstream economics, where outcomes are looked at in terms of utility and generally in terms of money. But we could also see this as being a quote that could replace the utility and happiness with health. So we could say it differs from the standard health-based approaches in not insisting that we must value only health, and sees instead the state of being healthy as one among several objects of value. So we could replace that happiness with health, and then I think we can see the applicability in terms of healthcare and health economics. So why do we want to capture more than health? I always think the example of a wheelchair is a really good one in terms of why we might want to go beyond health. Because if we give somebody a wheelchair, that doesn't improve their health at all, but it definitely improves their capabilities in life. So capabilities basically provides us with an alternative evaluative space. So this is just an example of hospice care. So if we were going to measure in the standard economic approach, we would think about that in terms of utility, which we could see as pleasure or satisfaction that we get from receiving that care. Or we could measure in the standard health economics approach, where we think about improvements in morbidity and mortality, which might be not that relevant at that stage of life. Or we could think about it in terms of capabilities. And so an example of what we might be interested in here might be the ability to make preparations. But what we're interested in essentially is what a person is able to do or be in their lives. So that gives us some information about capabilities. And now I just want to talk about the different about the development of the ICECAP measures and how that's been done. So the ICECAP measures are essentially measures of capability well-being, in that they focus on what a person is able to do or be in their lives. And so it draws a lot from the capability approach of Amartya Sen and people like Martha Nussbaum, but it also very much draws on some of the lessons from the QALY approach. So it's based on a number of dimensions in the same sort of way as a QALY measure is, and we aim to have meaningful values in the sense that those values are mathematically manipulable, I guess, really, in terms of being able to tell us quantitatively how one state relates to another state. But they do also differ in important ways from QALYs. They're based on what people themselves feel is important. So the way that the measures developed is different from the way most of the QALY measures have been developed. And it's anchored based on full capability and no capability. So it's not anchored on death. And I'll come back to that towards the end of the talk in terms of what that means for how we can analyse and think about the measure in decision making. So the development of the ICECAP for all the different versions has really involved 4 phases. So the first phase is one of in-depth interviews to generate the conceptual attributes for the measure, and they've been analysed generally using constant comparative methods, which are methods associated with grounded theory in more qualitative work. Then a second phase of semi-structured interviews to check the attributes and to develop meaningful wording for the measures. A third phase of valuation, which is primarily but not only used best worst scaling and generally amongst a relevant general population so that we can get these meaningful values that I talked about. And then a fourth phase where which is really a sort of going on forever type phase, where what we're interested in is the assessment of the measure in terms of how feasible it is to use, how valid it is, how reliable it is, and how sensitive it is to change. I'm just going to talk very briefly about the first and second phases in terms of the generation of attributes for the descriptive systems for the measures. So this is, as I said, is a two-phase process. So this is what the first phase looks like, basically a very circular type process where we start off with in-depth interviews to find out what's important to the informant. We might do that in batches of 2 or 3. We analyse those interviews, think about whether our conceptual attributes are fully defined. If they are, then we can move on to that second phase, and if not, we carry on until we've got all of our conceptual attributes defined. And then the second phase is very similar in terms of being still a very circular process, so using semi-structured interviews to explore lay terms for the measure, analysing those interviews, thinking about whether the terminology is properly defined. If yes, then we sort of say that that's the final attribute and the way it's described, or we might carry on for further iterations. And my experience has generally been that for most measures, there's around sort of 3 to 4 to 5 iterations before you get the right wording for all of your attributes. So what I'm going to do now is pass over to Isabella, who's going to talk about her PhD work, where she was generating capability attributes, conceptual attributes for young persons with life-threatening and life-limiting conditions. So I'll pass on to Isabella.
Thank you, Jo. So yes, I'm going to talk about developing the conceptual attributes for an end-of-life capability measure. And I've used as an example part of my PhD work, which was looking at capabilities for young people with life-threatening and life-limiting conditions. So basically, that is young people who may benefit at some point in their lives from end-of-life care interventions. And these conditions, and this is because a life-limiting condition is a condition that the child or young person is expected to live a short life. And those with life-threatening conditions are those conditions that curative treatment may be possible, but it may fail and result in death. So I was looking at the important capabilities of young people to develop the attributes for this measure. I think next slide, please. So there are child measures of health-related quality of life, and there are also adult end-of-life care measures that can be used in economic evaluation, but an outcome measure for children at the end of life has not yet been developed for use in economic evaluation. And the existing child measures have not been, it's suggested that they haven't been designed or validated for to be used in end-of-life populations. And then the adult end-of-life care measures may not be appropriate for use because they may not be able to capture what is important for these children and young people. And the terminology used in adult measures may also not be age appropriate for children as well. So as Jo mentioned earlier, standard measures focus on health and health functioning, that end-of-life care takes a more holistic approach with complex care interventions, and which they aim to improve quality of life, looking at prevention or relief of suffering, whether it's physical, spiritual, or psychosocial. So the impacts of these end-of-life care interventions may not be limited to changes in health. So my PhD work extended the application of the capability approach to end of life in looking at capabilities in young people, and to capture capabilities for young people with these conditions, and then use that information to develop the attributes for the measure. And in particular, I focused on young people who were aged 14 to 25 years old, because that is a challenging period for these young people, because they're going through transition to adult services, and adult and pediatric services are quite different in how they provide care. Next slide. Thank you. So to develop the attributes, I undertook online in-depth interviews with young people aged 14 to 25 with a life-limiting or life-threatening condition, or when young people had a condition that reduced their ability to communicate, I then interviewed a parent or a guardian. And later on in the data collection, the inclusion criteria shifted, and I included bereaved family members. So that's parents and siblings of young people who had died from a life-limiting or life-threatening condition. And this was not just because of recruitment difficulties, but also because we wanted to be able to capture experiences and what is important at the very end of life, which was difficult to do so with the existing participants. Thanks. So recruitment took place from January 21 to September 22, and we recruited through charities across England and Wales and hospices in England, and used different recruitment avenues, circulating study information, so like the ones that you can see on the left, through social media, newsletters, information boards, and also we did some snowball sampling from existing participants. The recruitment material we sought feedback from 2 young person advisory groups for the adverts and the participant information sheets to look at the layout and the language used in these materials before they were advertised to young people and participants. So the interview started with warm-up questions to help the participant feel comfortable, and to also give me a bit of context for the follow-up questions. So we asked about their hobbies and interests at the beginning. And then the interviews focused on the aspects of life that were important to the young person now and in the future, and why these things were important to them. There were 3 different topic guides for the 3 participant groups, so the young people, the parents, and bereaved family members, which were updated iteratively on an ongoing basis. And in particular, the topic guides changed. Additional questions were looking at what is important at the very end of life. And this is just the examples of the two topic guides. On the left is the young person one, and on the right the topic guide for bereaved family members. So as you can see, there's the questions are quite open-ended, but the bereaved, the one on the right, does have an extra question focusing on the end of life of the young person. The next slide, thanks. And so to develop the attributes, data collection and analysis was undertaken concurrently using the constant comparative method, and we started looking at doing some open coding, a line by line coding of the transcripts to look at what is being said. Then 3 coding schedules for the 3 participant groups were developed with themes and sub-themes, and then descriptive and analytic accounts were written, which helped to look at similarities and differences and to compare key themes between the groups of participants. There were 21 interviews in total with young people, family members. There were the experiences of young people from different backgrounds were captured, and in particular, there were many young people from the most deprived areas and from different ethnic minority groups, and different types of life-limiting and life-threatening conditions were captured in the accounts. So these are the findings. So there were 7 capability themes that were generated from the interviews. The first one was around being able to experience and enjoy life as much as possible, to have some normality in their life, and to live life beyond the medical. Then the second theme was around independence and being able to do things by themselves without having to rely on others, and to be left alone and have privacy if they wanted to. Then the next 2 were around physical and emotional suffering and wanting to be able to manage the physical symptoms and the impact of the symptoms on their daily life, as well as being able to have ways to cope when having difficult emotions, having distractions, and feeling useful to others as well. Then young people felt that it was important to have in their formal care and support, to have healthcare professionals with which they can spend enough time to build trust with them, and to feel that these people involved in the care delivery actually cared about them. The control theme was around being able to feel in control over health and care, having a say, be listened, and make choices, and also to be able to have information communicated in a language they could understand, the young people as well as the families. And the last theme was around identity, being able to maintain identity as a young person and to be valued and included and not judged or pitied by others. And that's the last slide for now. So the capability themes identified across the 3 groups of participants were similar, and that was also the case across the different types of conditions as well. And there were some shared themes with existing child measures, as well as adult end-of-life care measures, and also some similar themes with a pediatric palliative care measure, which is under development at the moment. These were shared themes around physical and mental, emotional health, and around care and support. But these existing measures did not capture all of the themes that were generated in this study, looking at broader well-being dimensions such as identity. So these attributes can be used to inform the development of a capability measure, but a lot of further work is needed, which I will talk about later on. Thank you.
Thanks, Isabella. So what I'm going to do now is just talk about briefly, I suppose, introduce the different ICECAP instruments. Some of you may have seen some of these before, but maybe not all of them. So the measures across the life course. So the first of those is the main adult measure, the ICECAP-A. And the ICECAP-A has 5 attributes of stability, attachment, autonomy, achievement, and enjoyment. And as Isabella showed you with the measure for young people at the end of life, there's sort of a number of issues that are captured within each of those measures. And the idea then is to try with the terminology to generate terminology which will capture all those different things within the items. So stability ends up for ICECAP-A being referred to as being able to feel settled and secure, attachment being able to have love, friendship and support, autonomy being able to be independent, achievement being able to achieve and progress, and enjoyment being able to have enjoyment and pleasure. And just so you can see what the measure looks like, this is the measure. It's a simple 1-page measure that can hopefully be incorporated relatively easily within a sort of trial or a study setting. And these are the values for the ICECAP-A. So you can see the bars represent the value at each of the different levels for each of the different attributes, and it's basically an additive measure. So if you have no capability on all attributes, then the value is 0, it adds to 0. Full capability on all attributes adds to 1, and the intermediate values are a sum of all the different intermediate levels. So for example, if you were a little capability on all attributes, then it would be a value of 0.43. So in terms of thinking about the ICECAP-A and its use in practice, and some of those issues around evidence for its use in evidence for its use in decision making and evidence for its sort of psychometric properties. There was a systematic review done by F&2 and Kinghorn in 2019, which found that the ICECAP-A, pulling from across different studies, has a good level of content validity, that associations that were identified as hypothesized between ICECAP-A and socioeconomic indicators, attitudinal indicators, and perceptions of freedom were found, and that they also looked at the associations between the ICECAP-A and other measures and found that there were consistently strong associations with the A-qual8D, which is an Australian measure, which is an Australian measure which incorporates more well-being attributes, I would say, and less strong with EQ5D. And there was also some work which found an empirical distinction between functioning and capability. So in their systematic review, they also looked at sensitivity to change and found that given that the measure is a generic measure, as you'd expect, it's not as sensitive to change as some condition-specific measures, but that's a very similar finding to something like the EQ5D. And they also looked at the use of the measure in evaluation and found some evidence that different interventions or patient populations would be prioritised if you moved from capability well-being to away from health functioning, and they also concluded that because it offers a broader set of outcomes, it can be considered more appropriate for use in economic evaluations of public health and social care. And I will come back to that question of might we prioritise different groups a little bit later. So in terms of the other measures across the life course, so there's a measure for older age, which is actually the first ICECAP measure that was developed, so the ICECAP-O. You can see the attributes look quite similar to those of the ICECAP-A. So for the ICECAP-O, there are attributes of attachment, which is phrased as love and friendship, security, which is phrased as thinking about the future without concern, role, which is about doing things that make you feel valued, and then enjoyment and pleasure, and control, which is worded as independence. And similarly, we've got the same sort of set of additive values here. And one of the things I think that's quite interesting with this one is just that the difference between having a lot of capability on all attributes and full capability on all attributes is not actually that high in terms of how people value those situations. The end of life measure, which Isabella's already talked about slightly. So this is the ICECAP SCM, and SCM stands for supportive care measure. And you can see this is a measure with slightly more attributes than the A and the O. And it has these 7 attributes around sort of love and friendship, which is, missed that out, choice, which is around having a say, love and friendship, which is around being with people who care about you, these physical suffering and emotional suffering attributes similar to what Isabella found for children and young people, and then attributes around dignity, being supported, and preparation, which is around things like having your funeral planned, resolving things that are important to you, making a living will, and so on. So if we look at those ICECAP SCM attributes in a little bit more detail, we can see that we've got attributes of 3 different types here. So we have 2 that are around health, we have 2 that are around care, and then we have 3 that are more sort of like the other capability attributes in the other measures. And when we look at the values, which again are done in a similar way, we can see something quite interesting, I think, about the health and care in the measure and how much influence those have. So if we look at the freedom from physical suffering and freedom from emotional suffering, we can see that actually they take up quite a small part of the total space. So they're only together about 15% of the value of the ICECAP SCM, whereas the care attributes, dignity and support, are around 40% of the value. So we can see that in the population there's more value given to those care attributes than there is to the health attributes at the end of life. The work we're doing at the moment is around generating measures for children and young people, and we're doing that by thinking about different age groups. And we're doing that again with direct research with children and young people, patients, but also talking to parents in some age groups. So we're looking at the whole age range from 0 to 18, and we're talking to parents up to age 16 and children and young people themselves from age 6. So the interviews that we've done have been a mix of face-to-face and online, because we got very caught up, as Isabella did, in the whole COVID problems with data collection, because we were recruiting originally through schools. But we tried to make our interviews engaging, to encourage the young children and young people to really fully take part in the work. So we use what's called hierarchical mapping as a starting exercise, where children and young people took a photo of themselves, which they enjoyed doing, and put it in the middle of this hierarchical map. So the map's on the bottom corner of the graph. And then we asked them to write post-it notes to reflect the things that were important to them. And then that was used as the basis for the interview. We've got 2 measures that have been finalised, but they aren't yet published. So the measure for 11 to 15s has 8 attributes, and that's actually with a journal at the moment. The measure for 6 to 11 has 7 attributes and is in the process of being put together for publication. And compared to just in brief, really, compared to the adult measures, There are some attributes that are a little bit different in these age groups. So there's an attribute around learning and experiencing. There's one around that brings in this idea of identity that Isabella talked about, and then one around being able to aspire to a future. So aspiration is what we've called it. We also used visuals to aid completion, and we tested a number of different formats. So we tried a words-only format like we have in the rest of the measures, which they said was boring and like an exam. So we didn't want to go down that route. We tried ladders, which they said didn't help. They didn't really understand it. And we tried plants, which they found unclear. And I think some felt depressing. I don't know if they thought the plant was dying. I'm not sure. That left us with two options, which were cups, although we called them cups, they often referred to them as batteries, and faces. But we had quite insightful comments around the faces from a couple of the young people who basically liked it, but said it wasn't just about the level of capability, but about how you felt about the capability. And that wasn't what we really wanted to convey. So we went with this option of cups. And this just shows you the two ICECAP CYP measures that we have so far. So the 11 to 15 one you can see has got more text on it. We tried really hard to make the text minimal on the measure for the 6 to 11, the primary age measure. So does a capability focus make a difference? So I'm just going to show you some information from one study. This is going to be a very quick part of the talk, but this is data from the multi-instrument comparison study, which was a study done across about 7 different countries, led from Australia by Jeff Richardson, where they asked people with different health conditions and the healthy public to complete a number of different types of measures, 2 of which were the ICECAP A and the EQ5D. And I think this is quite interesting in terms of just thinking about what the implications are of looking at health versus looking at capability. So this is the healthy public here, and we can see that compared to the healthy public, if we look at something like arthritis, we have a big drop in health in the arthritis group. But actually our capability is not such a big drop. And if we look at that compared to something like depression, we can see that there is a big drop in health, but also a big drop in depression. So that's sort of what I was getting at when I said that you might prioritize different things if you go down the route of looking at capabilities rather than looking at health. And that, of course, is a value judgment, really, about what you think is important. So just in terms of decision making with ICECAP, so what can we do with ICECAP and what can we not do? So we can do things, I think, that are similar to QALYs but are not the same. And that's because the way that we anchor with the capability measure makes it conceptually different from the way that we anchor with QALYs. So with QALYs, we anchor on perfect health and death, whereas with capabilities, we anchor on full capability and no capability. And we deal with death by saying that a person who has died has no capability. So while some people have referred to CALIs or capability adjusted life years, personally, I think that's problematic because of the different anchoring of the scale. So if you did anchor on death, then it wouldn't be. But I think because we don't anchor on death, it is problematic to do that. So instead, we've looked at analysis in terms of years of full capability gains or equivalent years of full capability gained. And there's a paper referred to there where you can find out more about years of full capability gained and what I'm going to talk about now, which is years of sufficient capability. So one of the things we've tried to do is look at the question about how might we want to think about some sort of distributional objective as well as just a sort of more of a maximization objective. So the idea of years of sufficient capability is that we can take account of equity considerations by focusing on absolute shortfalls in capability. And so the way that we think about this is by only giving weight to those who have an absolute deprivation in what they're able to do or be in life. So this very much draws on multidimensional poverty approaches, where what you try to do is identify a poverty level for each dimension. And by that, I mean a level of capability above which we're no longer concerned about that person's capability in policy terms. And then those who don't meet the criteria for poverty, we would censor, and we would recalibrate our values below that threshold to give this sufficient capability score on a 0 to 1 scale. And then, as with years of full capability, or indeed QALYs, we can introduce a longitudinal element by multiplying the score by time. So we can still do that longitudinal multiplication by time, but what it gives us is slightly different. So with sufficient capability, it will give us equivalent years of sufficient capability. So I've said conceptually different QALYs, but we can still do similar things. So we can compare our interventions in terms of gain in years of full capability or years of sufficient capability, and we can look at cost per years of full capability gained or cost per years of sufficient capability gained, so that we can then get as much additional sufficient capability from our resource as we can. So if we go down the sufficient capability route, essentially what we're doing is shifting from a more of a utilitarian approach where we maximize the total benefit to a mix of sufficiency, which means basically having a clear cutoff beyond which we don't intervene any further for a person because they've already got a level that we consider sufficient, with prioritarianism, which is about giving greater weight to those who are further from that threshold. So then the question becomes, well, what is our sufficient capability threshold? And fortunately, Phil Kinghorn at Birmingham has done some work on this with the Demand project, where he and his team have looked at trying to use participatory methods to determine what this level of sufficient capability is, and doing that through really quite intense full-day workshops with people who, as a result of being there all day, are properly informed and are able to have proper, open and reflective debate to determine what they thought about those levels of capability. And what they actually found was, it was interesting. I was involved in a couple of the groups, I think, and each of the individual groups did have different levels of sufficient capability. And then in the final group, one sort of representative from each group was brought together to make this final decision about the levels of sufficient capability, and essentially settled that at level 3 for each of the different capabilities on the ICECAP. So Phil's work has carried on and has done some further work about people's willingness to pay in additional taxes for a shift from no capability to this sufficient capability level of the third level on each of the attributes, and did the same sort of thing using deliberative workshops, and found a value of a year of sufficient capability at 33,500. So that's essentially equivalent to your QALY threshold value. Okay, so just to offer some final thoughts before we finish. So just to say that the ICECAP measures is a sort of ongoing thing. There is lots of potential to continue to look at validity and reliability across different types of settings and different types of interventions, and the measures included now in more than 550 studies across the globe. That's mainly ICECAP A and ICECAP O, but around 40 places are using ICECAP supportive care measure, and the ICECAP CYP is obviously very new, but there's a handful of people using that as well. In terms of the ongoing work for the children and young people quality of life study, so this is the work to develop the CYP measures. So there's valuation and validation work ongoing for both the 6 to 11 and the 11 to 15 measures. So we've collected the data and really are just the process of analysing all of that at the moment. The valuation for children and young people aged 11 to 15 has been done by children and young people aged 11 to 15. And we're hopeful that the tariffs for that will be available towards the end of the winter, and then the tariffs for the 6 to 11 measure in the spring of next year, and that's been done by parents as proxies for that age group. And in terms of validation, that's been done for self-completion by 11 to 15-year-olds, and for the 6 to 11 measure, we have validation work for self-completion by age 8 to 11 and proxy completion for age 6 to 11. And in terms of the ongoing development of the measures in those age 0 to 5 and 16 plus, we're still doing the work around the conceptual attribute generation for those age groups. So I'm just going to hand over to Isabella for one slide to tell us about further work for the young person end of life measure.
Yeah, I think I'm going to do it very quickly. So it's for the young person end of life measure, the further work is so the second phase using semi-structured interviews with the same population, so the young people, family members, including bereaved family members of young people with life-limiting and life-threatening conditions. And as Joe has mentioned, this second phase is to check the content and the coverage of the attributes that I talked about earlier, to see if it's meaningful for those young people who will be completing such a measure. And then the evaluation and assessment of validity, reliability, and sensitivity to change. Those are next phases that would need to be done if the measure is used in economic evaluation. And since there is a lack of measures for this population, it may be necessary to look at important outcomes for younger age groups at the end of life to see what is important to them as well. So that's it for me. Thank you.
Thank you, Isabella. And then just finally, I just want to acknowledge that this work is the work of really a lot of people, in terms of people, researchers, collaborators, advisory groups, and funders as well. A number of different funders have funded this work. And if you're interested in finding out more, the website is now at the University of Bristol. There's also a Twitter account and a number of publications. Thank you. I'll stop sharing if I can.